bringing up a really good point, and I haven't plugged anything, but I will plug. I do think melanoma patients deserve at least an opinion at a tertiary center that has a multidisciplinary look at patients, because you're right. I mean, this is not very straightforward, and there's a lot of complexity that we need to have patients that, that are experts that can think of all the different options.
And many times treating this disease is really sometimes more of an art than it is a science in knowing when to operate, when not to operate, when to give systemic therapy. And I think the more experts you can get in a room from different disciplines that can really give input to a particular case, the better outcome the patient has.
Absolutely.
To that point, actually, I think the one thing that we have not necessarily really thought about in treating our patients with melanoma is our colleagues in interventional radiology. We are doing more and more radiofrequency ablation also on solitary lesions, whether they're lung lesions and liver lesions. And often with that, it gives us an opportunity to do a biopsy first of the lesion to see if there is disease, and then consider radiofrequency ablation for that. So again, the whole coming back to the multidisciplinary approach in treating these patients.
I find it amazing that we're finding rules for collaborators, not just because we're losing control of disease, but because we want to gain a better control of disease these days. So we talked about the art of taking care of these patients. I don't want to forget the art of taking care of the toxicities and recognizing some of the toxicities that are important to physicians, such as the colitis and the dermatitis. So how do you treat your patients, Dr. Ampaka? Someone calls.
So fortunately, very few of my patients have colitis since I'm a surgical oncologist, but we do see these patients because we treat them in a multidisciplinary setting. And I think that again, what has been fantastic for me is that I treat this with my medical colleagues. So patients who have colitis from ipilimumab anti-CTLA-4, I think you have to be very much aware of that, especially inform the patient that if they have that diarrhea, or even if it's a mild diarrhea, to communicate back to the referring team. We also have a very low threshold of starting steroids on those patients. And I think that where I have seen this many times from, fortunately not in our own setting, but patients being referred to me that have been on ipilimumab and now have had a perforation of their colon or of their intestine, that can be a very devastating sequence of events for the patients with a high morbidity. So I think that being fully aware of this. So my colleagues in medical oncology are very, start steroids very soon for the patients. Fortunately, for most of those patients, starting steroids is sufficient to treat the colitis. But there are some patients also who may need, who have more severe colitis, that we may need other treatments such as Remicade to try to decrease the colitis and treat the colitis.
What I tell patients, even before they start, is the fact that you have a side effect does not mean that you're going to do better. So initial trials that we had, the patients weren't calling us thinking that to allow that immune system to get revved up and get a little bit of a worser diarrhea would lead to better response, and that's not true. And we know that you can go through these therapies and not have any toxicity and do well. You can go through these therapies and have toxicity and not have the response that you want. And we also know that if you are having a response with a toxicity, the initiation of steroids may not abrogate your response. So it will not have a negative effect on response. And I make it a point to be fairly clear about that for our patients.
Well, I think it's also important too, and I also give that same shtick about, you want to talk to us about side effects, but I also make it a point that patients are very focused on getting their therapies, whether it's every 2 weeks or every 3 weeks. And I really think it's important that patients understand that if you don't tell me about a toxicity and you're going to come in with that toxicity, you're probably not going to get treated that day. So it's always better to report your side effects and manage the toxicity before you walk in the office, because then you may be making the trip for me to just say we need to manage your toxicity and you're not going to get treated today.
Yeah, I think you know, the other thing I would add is I think some of the endocrine toxicities are often very challenging, and these patients can often present in a very subtle manner. You know, you can sometimes see a headache or a little bit of a mood change, and it's sometimes challenging. I think we've all become endocrinologists in taking care of patients on these checkpoint inhibitors. So, you know, we typically, you know, we'll check the labs before each of the doses, and we'll look at the thyroid function in particular. But I think if, you know, the patients are behaving in a strange way, you always have to keep in mind that there can be some endocrinopathies with this, and do the appropriate workup to look at the hormone levels. Again, I think early treatment has been very good, and I think we now have good algorithms for putting these patients on corticosteroids, and these can be very easily managed.
I find that the hypopituitarism can manifest in many different ways, from altered mental status to low-grade fever, to loss of weight, to abdominal pain, which can mimic, you know, disease progression and send these patients into a panic, and physicians that way. Again, as we talked about with the PD-1 toxicities, they may be rare, but it's so important to look for them at every visit.